All right. Good morning, everyone, or good afternoon, depending what time zone you're in. My name is Monette Zard. I'm the director of the program on forced migration and health that sits within the Department of Population and Family Health at Columbia University's Mailman School. I'm delighted to welcome you all to today's event, particularly those of you who were intrepid enough to come in person, because it is a very rainy, gray day here in New York, so thank you for braving the weather. And I would also like to thank Columbia Global for graciously hosting this event today. So our event today marks the release of a new study that explores the big questions in forced displacement and health, learning lessons from the experiences of Jordan, Colombia, Bangladesh, and the Democratic Republic of Congo. This study is the product of a consortium of researchers that included ourselves here at Columbia at the Mailman School, the American University of Beirut, Brandeis University, Georgetown University, and Universidad de los Andes in Colombia. Our work was supported by the World Bank, UK Aid, and UNHCR as part of an initiative that aims to provide evidence and guidance to strengthen systems, including health systems, to address the needs of displaced and host populations in contexts of protracted displacement. So I'd like to begin by turning it over to my colleagues from the World Bank. First, Dr. Fernando Montenegro Torres, who is a senior economist in the Health, Nutrition, and Population Global Practice Group. And he was the very kind and gracious task team leader for this particular project. And following him, Dr. Paola Elice will say a few words. Paola is the impact evaluation specialist in the Fragility, Conflict, and Violence Group, and she will say a few words about the bank's engagements on these issues. So Fernando, over to you.
Thank you very much. Nice to see all here and all the people connected online. Thank you very much for joining us this morning. When originally this project was proposed by my colleague Aaka Pande, it was considered that it would be a bit too complicated to carry it out. Too many factors, too many health system, economic, and even political economy factors. Having said that, I'm so happy that this project has finally get to this stage, even though we had a COVID crisis in the middle. And I think that we want really to make sure that all the lessons and all the discussions can be discussed, disseminated, and learn about. Obviously, this is not the last word, but it's a key milestone for the bank and for all the stakeholders in working in this area. So I just wanted to say again that this is a project originally conceived by my colleague Aaka Pande, who unfortunately passed away, and I was more than happy to take over this project that she originally conceived and that I want to acknowledge. That's all on my side. I think that the key issue is just to share the knowledge, and we'll hear from the consortium what are the key results, and let's look forward to the dialogue. So, Paola, over to you.
And thank you, Monette. My intervention today will be very brief, and it's meant to provide more context and to situate this health global study. Today's study is part of a broader research program of displacement named Building the Evidence, and it is a partnership between the UK government, the UNHCR, and the World Bank. The program's objective is to support the World Bank, the UNHCR, the UK government, and other actors working in contexts of forced displacement, including, of course, governments themselves, design effective policies and programs to support displaced people and host communities worldwide. Getting to this chart, which you can see in the first slide, this shows that there has been an exponential growth over the course of the past 6 years in the number of research papers, economics research papers, focusing on forced displacement. If we run a simple search on econ papers, we can see, and we search for refugees and internally displaced people, we can see a 6-fold increase in the number of economics papers. Similarly, if we run a search for migrants, we see a 3-fold increase in the number of economics papers. Next slide, please. The Building the Evidence program, Building the Evidence on Protracted Forced Displacement program, contributes to this economics research effort and has been implemented in over the course of the past 6 years with a 16 million budget funding USD from the UK government. The program includes 6 global studies. These are thematic studies. The health one is one of the 6. It includes also impact evaluations of specific programs or projects. It includes focus studies on questions of particular interest, a microdata initiative, which has evolved into the funding establishment of the Joint Data Center on Forced Displacement, a Young Fellows program, and the establishment of a data portal, including curated data on forced displacement research, and more broadly, fragility, conflict, and violence research. Next slide, please. This is to conclude. As you can see, the program has a broad thematic and geographic reach. It includes, we've counted more than 130 studies. And if we look at the health studies, there's 16 research products. And a lot of the research under the health team will be covered during today's event. Thank you, and back to you, Monette.
Thank you, Paola. Thank you so much. So let me tell you a little bit about the Big Question study itself. First of all, our work focused on the humanitarian health response and its relationship to national health systems in low and middle income settings in situations of protracted displacement. So we set out to identify optimal approaches that could respond to the health needs of displaced populations while also strengthening health systems for the host populations that live alongside them. So we focused on identifying practices and approaches that could work to advance health access and quality, exploring how these approaches could be best costed and financed, and identifying pitfalls to avoid. And the team of researchers in this consortium really consciously reflected that mix of expertise drawn across these sectors of humanitarian health and practice, health systems expertise, and health financing expertise. And this slide, I think, tries to portray that group itself. This next slide, I think, also shows that in addition to this core group of researchers, in each of our study sites, we were fortunate enough to work with a remarkable group of national experts who also reflected this range of expertise and who helped ground our findings and recommendations in the reality of those places. We conducted research in 4 study sites that were intentionally selected to represent different contexts of displacement. There we go. So different contexts of displacement and humanitarian response: Bangladesh, Colombia, the Democratic Republic of Congo, and Jordan, each represented a range of macroeconomic contexts drawn from across low and middle income settings. There were different types of displaced populations, different legal and political contexts, obviously, and different durations of displacement. We focused our work on 3 broad questions. First of all, what were the common trends, similarities, and differences in the health needs of forcibly displaced populations and host communities beyond that initial emergency response? Secondly, what evidence and examples of good practice were available as to optimal ways for host countries and development partners to be better prepared to systematically identify, prioritize, plan, and deliver health services at all levels of care for both host communities and displaced populations? And then finally, what are the most cost-efficient mechanisms for financing health services in these contexts? So to answer these questions, We used a mix of quantitative and qualitative methods. Obviously, all the usual literature review, key informant interviews, looking at the secondary data. We also built in focus group discussions and in-depth interviews with refugee, displaced populations themselves and host communities so that we could bring in their perspectives to the research. And we also had a range of health provider questionnaires and health facility assessments to help provide a snapshot of system readiness to manage a range of sort of common conditions, from emergency care, including surgical capacity, through to the management of chronic diseases and routine vaccinations. So a final word on COVID. Like everyone, we had to adapt over the last few years to accommodate the reality of the pandemic, and our research was suspended for several months. And while we waited, the consortium generated a series of desk-based knowledge briefs that addressed how the humanitarian health system was responding to the challenge of COVID-19 in the context of displacement. And these are all linked and identified here. So what I'd like to do next is turn it over to some of my consortium colleagues to walk you through some of our findings. Our first speaker will be Dr. Claire Green, who's an assistant professor in the Department of Population and Family Health in the program on forced migration and health at the Mailman School. Dr. Green will review our findings from Bangladesh. She'll hand it off to Dr. Fuad, who's with us on Zoom. He is an associate professor of public health at the American University of Beirut and the IDRC chair in forced displacement in the Middle East, and he will review Jordan. Next, we will have Gang Augustine Karume on Zoom and Dr. Les Roberts in person. Gang is the executive director of Rebuild Hope for Africa, and Dr. Roberts is professor emeritus in the program on forced migration and health, and they will together review the findings from DRC. And then Dr. Diana Bowser, also on Zoom, who is an associate professor at the Institute for Global Health at the Heller School for Social Policy and Management at Brandeis, will review Colombia. Their reflections will be followed by some from Dr. Wu Zheng, who is an associate professor and research director in the Department of Global Health, School of Health at Georgetown University. And Wu will be sharing some of our collective findings on costing and financing. And then finally, Catherine McCann, senior program officer in the program on forced migration and health, will share some of the overall findings and conclusions from the project as a whole. So never fear. Even after that lineup, there will be time for questions, so do be thinking about any questions you want to pose for our panelists, and we'll take them both from folks who are online as well as those in the audience here. So do be thinking. But without further ado, I think I'd like to hand it off to Dr. Green. Claire.
Thanks, everyone, for being here today. It's a real pleasure to have the opportunity to present on behalf of this collective team some of our findings from Bangladesh. And I also want to acknowledge Dr. Sarah Casey, who's in the room today, who really got this case study off the ground in the early stages of the project. So today I'll be I'll be focusing on the health response for Rohingya refugees in Cox's Bazar, Bangladesh. So the Rohingya are a Muslim ethnic minority group from Myanmar who have experienced decades of violence, of human rights violations that have really forced their displacement from Myanmar into other parts of the world, particularly in the neighboring region of Cox's Bazar in Bangladesh. And we've seen several waves of displacement over the past several decades. Most recently, one of the largest scale displacements occurred after the severe escalation of violence in August of 2017. It's estimated that about 1 million Rohingya refugees reside in camps and settlements in Cox's Bazar. And I think it's really important to note that displaced Rohingya in Bangladesh do not have legal refugee status. And this has really important implications for their right to work, for access to different services and systems like education, as well as their freedom of movement. You may see the term forcibly displaced Myanmar nationals, which is the designation that they've been given by the government in Bangladesh. I wanted to provide this very simplified overview of the organization of the health response in Bangladesh, just to provide some context before I go into some of our findings. So the humanitarian health system in Bangladesh for Rohingya refugees is coordinated by the government of Bangladesh, specifically the Ministry of Health and Family Welfare, as well as the World Health Organization. And together they coordinate services provided by approximately 100 partners within these camps and settlements. And these services are primarily primary care services. They largely serve refugees, but also to some extent the host population in neighboring communities as well. For refugees who require more specialized services or services not available within the camps, they require getting referred out into the national health system, which is a bit of a complicated process, as they also have to get legal permission in order for them to leave the camp. And this will come up in some of our findings in a few slides. So through focus group discussions and in-depth interviews, we identified a few challenges as far as the health response that I wanted to highlight. The first is the limited availability of services, so the limited kind of range of services provided within the camps, limited human resources, limited medication supplies, and all of these factors led to long wait times, to refugees having to seek alternative forms of care through informal or private services and systems that often accrued a cost, as well as really inefficient referral systems. Although services in the camps are designed to be free of charge, there were additional costs associated with seeking services that was described as one of the biggest barriers to care, especially if they had to seek services outside of the formal health system within the camps. Other barriers to accessing care were things like legal permissions, discrimination, and physical barriers, meaning kind of proximity or difficulty kind of physically accessing services within the camps. We also identified several acceptability issues, which related to often gender and language and cultural appropriateness of care. Here's a quote from a refugee we interviewed who described how when they seek services within the health post, they often have trouble explaining their health issues to the staff there because they don't speak Bengali and the staff there don't speak their language. In one of our focus groups, one of the refugees who was a member of that group, I think, nicely articulated many of these challenges, so I wanted to share this quote with you. Here he says, "We do not get proper treatment here. When a patient with a serious disease goes to a hospital, hospital staff say they do not have medicines for serious diseases and tell the patient to go to another hospital, and that hospital refers to another hospital. We're suffering like this. We don't have money to go to Cox's Bazar for treatment, and getting permission from the camp in charge is also a problem for us. Many people died in the circle of getting permission and being referred to other hospitals." We also wanted to collect information about how data are collected and used to inform the health response. And really central to this were the facility and community-based disease surveillance systems that were operating within the camps, primarily to monitor infectious diseases. And one of the key findings related to disease surveillance that I thought was quite interesting aligns with what Monette was saying, in that this work was being done during a pandemic. And what they had found was that during the early stages of the pandemic, there were a lot of investments in terms of capacity and technologies and really building out this system of disease surveillance that has since had spillover effects to improve the timeliness and sensitivity of disease surveillance within Cox's Bazar to detect even other infectious disease outbreaks or upsurges in the case of dengue, for example, as shown on this first quote. In addition to these types of data, the health sector also collects data from facilities as well as system-level mappings to understand the activities related to health that are ongoing in the camps. But one thing that I thought was notable was that a lot of the actors were very aware of what type of data were collected, but as highlighted in this second quote, it was very unclear how those data were actually being used to inform decision-making around the health response. Another key theme that came up was related to human resources and some of the challenges with high rates of turnover, with difficulty filling health worker vacancies, with some of the health workers having never worked with refugee populations before and not feeling like they were not adequately prepared to do so. And so here I've highlighted just a few of the strategies that were mentioned by people we interviewed throughout this project. And I just want to highlight two of them. The first was really what the health sector was investing in to improve and strengthen human resources, which is the idea that models of training and supervision should really be standardized and improved in order to promote consistency across health facilities within the camps. And the last one that I wanted to highlight, or I guess the second to last, is a strategy that has been used, I think, really creatively and was really promoted by several of the stakeholders we interviewed that focused on including refugees within the health workforce. There were some really good examples of this in the mental health and psychosocial support field, where refugees were part of the health response and promoted acceptability and accessibility of these services. Just to end, I wanted to provide an example from a facility that was really highly regarded within the camps. So we heard from our focus groups that were conducted in close proximity to this facility a very different narrative about the health response than some of our focus groups conducted in other spaces and camps throughout the area of Cox's Bazar. And so we went to some of the staff at this facility to understand their approach, what made them different. And I really appreciate this quote from one of their nurses that talks about their focus on respect and on dignity, their approach to including Rohingya volunteers in the health workforce, and also making sure there was representation across religious and cultural identities. And to me, I just want to end, I think, with this principle that I think we sometimes forget when discussing kind of health systems, is just the importance of centering refugees within the experience of healthcare, and thinking about maintaining these principles of inclusivity, of respect, and of dignity, and how kind of salient and how much that resonates with the communities we're working with. So I'll leave you there and now turn it over to my colleague, Dr. Fawad, for some lessons from Jordan. Thanks.
Well, thank you, Claire. This is very interesting. Of course, I'm just, seeing your slides. So, thank you very much for giving me this opportunity to present on behalf of my colleagues in Jordan, in the Jordan University of Science and Technology, and my friends and colleagues at the American University of Beirut on lessons from Jordan. Next, please. Next. So this just to reflect quickly on the Syrian situation in Jordan. So as you may know, that the number of registered Syrian refugees in Jordan is over 600,000 as per UNHCR, whereas the Jordanian government estimate the number by double, so almost like a 1.54 million, making Jordan a second highest refugee population per capita after, following Lebanon. Almost like a 20% only of them are in camps, whereas more than 80% are in urban settlements, including Amman, Mafraq, Irbid, Zarqa, and the Balqa. Jordan is a country that hosts refugees since decades, starting from Palestinian refugees and Iraqi refugees, and now the Syrians. Next, please. So just to give a sort of few hints about also the situation in Jordan, the country of the most water stressed in the world, with the issue of 23% are unemployed. The existence of refugees put like a burden on the infrastructure and the sort of competing on job opportunities and other state-provided services. The Jordan government estimates annual cost of hosting Syrian refugees in Jordan by $1.5 billion US. Next, please. As for the health system in Jordan, it's a mix of public and private sector, where around almost 50% of the beds are in public hospitals. Jordan has a national e-health system, and the country is currently expanding its home healthcare policies as sort of a new method to provide healthcare services. It's also like putting like a more expenditure on healthcare, and that go to issue of newer methods of treatment and expanding healthcare. Also, the government introduced a national health insurance system to provide large-scale accessibility to health insurance, and the issue of providing, of course, like a sort of health care assistance to refugees, whereas we see now that it begins to decline due to the finance burden on the government budget. Next, please. Next. Monet explained the methodology, so where we interviewed two sets of key informants to assess the health needs and the finance aspects of health expenditure. Also doing like a focus groups, surveys to do like a health facility assessment in almost like a 22 health facilities, and conducted a survey with 200 providers from different health facilities. Next. Next, please. This is about the findings here. So, Jordanian healthcare system reported to be overburdened since the first Syrian influx in 2011-12. And this is clear from all the findings that we have from interviews with the key informant. But this is only worsened by the decrease in the physician-to-patient ratio because of the lack of, or decline the number of physicians in the country. The healthcare burden is demonstrated by the lack of finance coverage. The study also showed a low grade for health facility readiness, and the main barriers that the study showed include indirect and direct costs, long waiting times, transportation, social stigma, and discrimination. Next, please. From the focus group discussion, the findings on health needs showed that there are several health needs and services that are not covered, including dental services and some specific services on heart diseases. Most of the medication are not available, and the process of approval to cover some of health services are very lengthy, and the decision process of the UNHCR is not clear to patients, whom they commented as an unfair process. As for fund and affordability, the study showed that there's a pressure on health services, and so people that force people actually to seek private care, although very costly. Inside the camp, all services are free, however, not comprehensive, but outside the camp, they have to pay, although most services are provided. Next, please. In terms of affordability, this lack of affordability leads Syrians to either not to seek care or to borrow money to seek private care from the private sector, and to prioritize the health of family members. In terms of stigmatized population, our observation and from the some Syrian interviewed, so we noted that some healthcare providers treat them with a little dignity and respect. This is something that Claire mentioned also among Rohingya. Next, please. Other findings from the key informant related to availability of fund mentioned that there's no stability in the fund. COVID-19 is not a major cause of fund instability, which is an interesting finding. And now comparing with the beginning, now the fund is provided to the, in the beginning actually it was provided to directly from NGOs, but now all fund is provided to the Ministry of Health and Ministry of Planning and International Cooperation. So in terms of health needs and providers, there's no, the study shows that there's no difference in health needs between Syrian and Jordanian, especially the vulnerable Jordanian and the lowest socioeconomic status. There's a strong correlation between health needs and the socioeconomic status for both the host countries and the cities. Next. Also, we found that there's no difference in the way of communication and quality of service between both host and refugees, even though most NGOs provide services for Syrian refugees more than host communities. One of the issues that was clear and reflected on the study is about the Syrian with the health backgrounds. Those are restricted. There's sort of restriction to work and are not allowed to practice. This is due to the Jordanian licensing issues and sort of the regulation there. Next, please. Brain drain remain a challenge in Jordan. This is an old issue, but we keep seeing that. Workforce skill sets are not optimally allocated within the healthcare system. Especially we found gaps in some services, including mental health, and there's a limited availability of specialized doctors. Next, please. And actually, this slide shows the main formal training that received in the last 2 years. That means during COVID, and so it's not surprised to see the most training went to infectious and prevention and control of diabetes, and in addition to a neonatal and family planning. Next, please. So to conclude here, our finding indicates a limited capacity of health facilities to provide health services. And both Jordanian and Syrian refugees still face many obstacles in accessing healthcare, and the future system should explore leveraging the strength of the three sectors, the public, private, and the NGOs to improve health services for refugees. The main characteristic one defined is the financial sustainability, which is the most critical challenge, and improving the healthcare of refugees and the vulnerable Jordanians require a sort of multi-sectoral approach to address health-related social needs, including employment for both refugees and nationals. I will end up here, and I will handle it to Gang and Liz for their presentation. Thank you very much.
Thank you, Dr. Fuad. Thank you, Professor Claire, for your presentations. I'm happy to present to you on DRC, and our presentation is articulated around 5 points. We just have 5 slides where we are going to present the context, the DRC context, where we are going to say what we did for data collection. Then we are going to talk about the IDP's integration in DRC health system, and talk about also the human resources and their health structures, and we are going finally to conclude. First slide, please. Next slide, please. No, come back to the first, please. Come back to the previous, please. To the previous slide, please. Yes, as you can see there, what I could say, it's not fun. It's absolutely not fun living in DRC for the moment. The figures there are really, really clear on what the DRC situation is for the moment. 73% of DRC below international poverty rate. 1994, with the Rwandan genocide that triggered a massive influx of people into DRC. Then the Rwandan invasion in 1998, that put in place a government that is just working for Rwanda to just be honest and to tell the truth blankly. And this has conducted up to 34 years of instability in the country. Actually, we are limited by the time constraint, but we would really write a whole book about the DRC context and the hardship that is going around here, because on this, we don't even cite epidemics, we don't cite inter-ethnic and community conflicts, we don't talk about natural disasters, we don't talk about so many things. But I would advise you guys to read, Jason Stearns wrote two really good books that would inspire you on the DRC context. The one is Dancing on the Glory of Monsters, and the second one is The Word That Does Not Say Its Name. If you read Jason Stearns' books, you'll be really inspired on the context. Next slide, please. What did we actually do to collect data? Can you go to the next slide, please? Can you hear me, please? Can you hear me?
Yes, we can hear you now.
I can hear you.
Yes, I was saying, can you move to the, no, come back to previous slide, please. Yes. What we did is, we worked, DRC has 26 provinces, but we picked up one province that we visited into its three major components, the north, the center, and the south. We visited in the north, the Kalehe territory, the South Kivu province that actually our study was carried out in has 8 territories. And we visited Kalehe territory that is up north. We visited the city, the town of Bukavu that is in the center. And we visited the territory of Uvira that is down in the south. And in Uvira, we visited 2 health centers, plus the city of Uvira itself. What we did is we carried out 3 most populated RDPs. We visited 3 most populated RDP areas. We conducted 12 interviews, 12 rural focus groups, and we visited hospitals and clinics, as you can see on the screen. Next slide, please. Yes, here it is really, really clear. I think there is no comment on this. I need to be really clear on this. If you ask me the question, are RDPs integrated into DRC health system? The answer is clear, it's no. And you can see there the number of facts and reasons why I can say no. The funding that comes from hospital and clinical operations come from the provincial authority directly. You have faith-based structures that came to complement those gaps that are left behind by the provisional authority in South Kivu province. You have also some public campaigns that are health campaigns that are undermined by actions at the hospital level, such as the fees and the multiple donors. The multiple donors and international players that are creating kind of inefficiencies. And here, there is really, you can see the graph. You can see the graph there, where at one point in time in 2010, where health structures were founded by BPRM, and then when they exited, you can look at the visits per month, how it declined in 2011 and 2012. And here there is really a really harsh and tricky question to ask. Yes, okay. The health systems are supposed to be financially standing alone, but they just can't. Now, do we leave people stranded and die, or do we bring outside intervention to keep people alive? And in doing that, we are going to put at jeopardy the already dying system. And we just wonder what happens. What do we do? Do we keep the system ongoing with its failures? Do we bring an external support and jeopardizing the system? The question is still there. Next slide, please. About the human resources and the health structures functioning, as you can see here, we are not even reaching, we are even below the WHO recommended numbers. We are not there yet. And listen, many expected services like family planning, blood transfusions, they are not available for lack of resources. And we have to say that the UN, the international organizations do not really help out the situation in poaching the good quality staff from the state facilities and giving them better salaries, better conditions. And this is not also supporting not helping out the situation. But I would say staff are generally not overworked, because clinical utilization is very, very extremely limited. The attendance is really limited. Next slide, please. The conclusions are, as we really heard about it from Professor Claire, money is also a barrier, a serious barrier to healthcare access in DRC. And this was repeated in the 12 focus group discussions we did, and the 12 interviews we did with our key informant. It was just coming again and again and again and again. Money is really a problem. And I said, let's not make any confusion about this. There is no system to address the displaced health situation. And when clinical care is free, as it is it was the case in one of the red clinical visits in a displaced camp, utilization is really, really high, and the population attitudes are positive. And as I said, there is that dilemma of putting at jeopardy the national health system and not let people die. That paradigm is there, and we have to know exactly how to handle it. And the cost barrier trigger many mechanisms that prevent the health system from improving. It's a problem, but again, the question is on table. How do we handle it? I would stop from here, but Professor Les, do you have something to add on what I've said?
Thank you, Gang. That was wonderful.
Hand over the word to Diana, please.
Yeah, we're out of time. So I just want to emphasize Gang's last point there. It is hard to articulate how extreme the cost barriers create synergies that destroy the health system. If you read the transcripts from the focus groups, you would think 25% of all patients in hospitals are kept as hostages or prisoners until the family pays their bills. It's probably not even 1% in reality, but that occasional event creates enormous fear in the population. And when they start going to the local healers, traditional healers for healthcare because they can't afford the hospital. It reinforces them and so on. So Diana, we'd like to hand over to you and the group from Colombia. Thank you again, gang.
Great. Thank you so much. Delighted to be here. These presentations have been wonderful. And what I'm going to do now is present reflections on Colombia. And I'll be giving key findings on the health system integration, a little bit on the data and surveillance, and human capital and innovations and challenges moving ahead. We can go to the next slide. And while you do that, I'll just acknowledge that this is a team effort. I'm presenting on behalf of the entire Colombian team and my partners at Brandeis University as well. I just want to acknowledge Professor Arturo Harker Roa, who was the PI in Colombia and really led this wonderful piece of work. So the first thing that we wanted to highlight are a few contextual issues with regard to Colombia and the healthcare system. And the first one being is that there's not only one migration crisis going on in Colombia, but there are two migration crises going on in Colombia. In this slide, you can see two figures that show the extent to these crises. I really like the first figure here on my bottom left, which shows actually the crises for many of the populations that we've already heard about in this presentation. And you can see here the line for the Venezuelan migrants, which are projected upwards of 6.5 million Venezuelans that have left the country of Venezuela. 2 million of those are residing in Colombia. So that's crisis number one. And the second situation is with the internally displaced populations. And we just provided a timeline here because you can see that this is not a new situation. This has been going on for many years. And as a result, and I'll show you in the next slide, I think Colombia has been quite resilient with regard to their healthcare system in terms of providing services to not only Venezuelan migrants, but learned lots of lessons from being flexible with their system as they expanded options for the internally displaced. Okay, yeah, you can stay on this slide here. The second contextual piece that we wanted to mention is that Colombia has been experimenting and working on universal health coverage for many, many years. They have developed a fairly robust program of social health insurance where citizens are eligible to apply and enroll in several different health insurance schemes, which you can see here in the slide. The blue bars are the Colombian nationals, and you can see here there's two major schemes. One is a contributory scheme, which is mainly for the formal sector, and the second one is a subsidized regime where the premium is subsidized by different financing from the government. And you can see here that the blue bars add up to about 97%, meaning that about 97% of Colombians are enrolled in either of these schemes. The orange bars are the Venezuelan migrants. Once they have particular paperwork in Colombia, they can enroll in either of these schemes. And you can see here only about 1/4 of Venezuelan migrants. And this is with a sampled population, not the entire population, are enrolled in these either contributory or subsidized regimes, leaving about 75% of Venezuelans in Colombia unenrolled in any scheme. So the next slide shows you can go next slide. We did a lot of work analyzing and understanding not only access to healthcare services, but quality of healthcare services offered to both Venezuelans and Colombians, looking at the disparity in those. You can refer to our paper and our report for more information on lots of this information. I think these two graphs capture fairly nicely what we found is that for many emergency services, which you can see here on the left, there's a constitutional requirement in Colombia that everyone that shows up to a healthcare facility needs to be provided emergency care. And you can see here that the Colombian government does very well at providing that care fairly equally to both Venezuelans and Colombians. The Venezuelans are the red dots and the Colombians are the blue. However, if you go to the right-hand graph here, you can see that when we looked at all-cause consultation, so this is access to kind of a physician and more continuous comprehensive care, there's quite a disparity between the Colombians and the Venezuelans. And you can see here we captured that and estimated that to be Colombians having almost 7 times the rate of consultations with a physician in comparison to Venezuelans. Please go to the next slide. I think, yeah. So on the next slide, I show you that we were very, very fortunate in Colombia that we had access to lots and lots of data. And they do a really great job in Colombia of collecting all of this data. And much of this data is available for not only Colombians, but also you can break that down by Venezuelan populations as well as the internally displaced. And you can see here that we had lots of information on utilization, patient characteristics, even costs. And so we were able to do a lot of analysis with that data. And these data are used strategically by the Colombian government and local governments to develop local health plans. And they've also created a wonderful dashboard that gives access to much of this information so that local entities can also plan for the populations that they're serving in their areas. One thing that we did note is that there does need to be more coordination with many of the donors who are also providing services, and the 75 members of the GIFMM. And this would help in reducing the duplication of data collection efforts and provide a more comprehensive picture of what's going on around the country, which is quite varied depending on the different areas that are offering services to Venezuelan migrants. Next slide. We wanted to note just some innovations and also challenges with regard to human capital based on the results of our findings. We noted in the analysis that we did with the quantitative data and also much of our key informant interviews that Colombian healthcare providers are quite innovative with regard to the services they provide to all populations and to Venezuelan migrants. If you read our report, there's a number of different case studies. We noted that there's one example of a healthcare system, a network of public hospitals who work to ensure the highest quality of care, especially for pregnant Venezuelan migrants who are entering Colombia, oftentimes without any prior antenatal care visits, or the Colombian providers not knowing what type of services they receive before entering. And they've done a wonderful job of providing services to these types of populations. Upwards of more than 500,000 displaced Venezuelans have received services through these systems. For the migrant human capital, we did want to note that the Venezuelans are allowed to register for permanency status in Colombia, of which at that point they are allowed to gain employment and qualify for key education and health benefits. And I think there's some challenges there, enrolling as many Venezuelan migrants as possible, but this is a key opportunity. Some challenges still remain in expanding these employment opportunities, as well to Venezuelan health professionals who are very keen on working in the Colombian system, but there are some political and legal barriers there as well. So my final slide just outlines some ongoing innovations and challenges that we noted in our study, especially through the key informant interviews. The first one that I'll note is the Colombian government has been very supportive of Venezuelan migrants, especially offering them this special permanent of residence, which allows them to have access to employment and other health and educational benefits. In February of 2021, the government went even further and expanded the process of regularization that now allows 1.8 million Venezuelan migrants residing in Colombia to obtain a 10-year temporary permit for residence, which we would hope would increase the access to healthcare services, health insurance, and other benefits. However, there is still low enrollment in this regularization status for many Venezuelan migrants, and hence, as we saw, low enrollment in some of these more formal health insurance schemes. This provides and then leads to a lot of financial instability for the entire healthcare system, which we looked at closely in our report. And this would be only intensified as more services are offered to migrants and IDPs. We also noted in our report limited mental health and psychosocial support, especially for Venezuelan migrants, and limitations with regard to access to chronic disease and preventive care, which is still quite a barrier for our migrants, especially those with specific conditions like HIV and those that need prenatal and perinatal services. So thank you so much. Much more information is available, but I know I had limited time for the presentation. Thank you.
All right, so in this session, I'm going to present some of the findings on the cost and the financing of health services for the displaced population from all these 4 case studies. And the cost and the financing basically are the 2 sides of a coin. For the demand side, they care more about the cost and also care about the out-of-pocket spending. But from the supply side, like donors, and governments, they care more about the financing, where the money comes from, how the money is used. So we'll basically just summarize some findings from this. And so from previous case studies, you may have heard that most of the services are provided by NGOs or government facilities for displaced population for free. But even it's free care, but we still see a lot of kind of out-of-pocket spending. It is still significant barriers for them to access to care. And there are many reasons why there are out-of-pocket spending. I just want to highlight 2. The first first issues is more about the unavailability of the healthcare services. And the free care is mostly focused on the primary care. But for some cares like dental care, the care for the non-communicable diseases, and some surgical services are not available at the primary care settings. So they have to go out in the private settings and like private hospitals or private clinics to get care. Sometimes they want to get medication, but medication is not in the health facilities. They may go to the private pharmacies to get drugs and so on. Another thing I want to highlight is about referral. When people get more severe conditions, they need to revert to the high level of hospital. Generally, might be outside the refugee camps. Then the transportation cost can be quite high. And sometimes they also need to have the people like caretakers to accompany them. The cost of accommodation, cost of meals can be quite high. That also affects the cost as well. There are some other factors that also affect the cost. Legal status is an important one. I think Colombia is a good example. And if you are legal Venezuelan migrants, basically health services are covered by health insurance. But if you are not, then only emergency care or vaccinations are covered. You have to pay out of pocket to get some other cares. During the COVID-19 lockdown period, and when referral needed, they don't want to go to the hospital far away. There is also a tedious kind of a paperwork you need to do in order to get out of the camp. So people tend to just get the care from the nearby private clinics. That also affect the cost. Quality care is another issues that drive the patients away from seeking care in the NGOs and the government facilities. Next slide. From the financing side, there's no doubt the donor funding is the major sources of funding. I think that's quite understandable because of the displaced populations is relatively poor. They don't have enough financial resources to contribute to health insurance schemes. So the government or donors need to take the major responsibility to finance their services. Improving financing is not easy. It is quite complicated, and they're also facing a lot of challenges. One of the major challenges is the shortage of funding. I think this is quite common across the board. But what I want to say here, because the refugee response is quite comprehensive, it's not just health, but also like education, food security, and other sectors got involved as well. If we look at all the sectors we have, the health perhaps is the sector with the largest shortage of funding in terms of percentage. And there are also some new issues coming, like Russia-Ukraine war. There's added more complexity to the pictures, and there is donor fatigue, and in some of the settings, and these new issues also divert the donors' attention. So that will affect the stability of the funding. What we observed is in the first 2 years or 3 years of the displacement, we see there's an increase of funding, and then the funding becomes irregular. And this has to do with the priority of the donors and also the attention diverted to other places. There are many donors and organizations got involved in either funding the services or delivering the services. And coordination becomes a big issue since there are so many organizations got involved. And we know there are many efforts ongoing to help to coordinate or harmonize the fundings, but we do see some of fragmentation of the services, like duplication of the services in some areas that need to be further strengthened. The unavailability of the services also highlights that we may need to update the benefit design or a benefit package design for the displaced population. And chronic conditions, mental health, and drug or pharmaceutical issues becomes more and more important for the refugee population in some of the countries we studied. And the benefit package design need to reflect the health needs of the populations. And these 4 countries also reflect different levels of the integration of the refugee health in the healthcare system, from the least integration in Rohingya populations in Bangladesh to more advanced integration in Colombia. Integration seems it's a more sustainable approach to finance the health services. But if we want to achieve that, perhaps it's important to have both donors and the host government to work on it at the beginning of the displacement when these things happen. And also, integration is not easy. It requires very strong political commitment of the host governments. And perhaps the first thing we need to change is we should not treat the refugees or the displaced population as a burden, rather than treat them as a human capital. They can contribute to the economy. They should be provided with the opportunities to generate income. Hopefully, in the future, they can also contribute to, at least partially, for the health services. So I will stop here on the financing and the cost and give the floor to Catherine.
Thank you so much, Wu, and thank you, everyone. It's a pleasure being able to speak with you today. And Wu has already started to cover some of the elements and touch on some of the elements that I want to talk about. So we hope this project can serve as providing recommendations and serving as a roadmap to improve the quality and expand the capacity of national health systems to promote the health and well-being of displaced and refugee populations, as well as the host populations they live alongside. No singular approach can accommodate the diversity of political realities, capacity constraints, and varied health needs that exist across the different hosting contexts. But planning and integration serves as the foundation for an effective response. Communication and coordination across national and international actors enable efficient assessment of health needs and health gaps, and allow for targeted interventions to strengthen the health system and, as Wu mentioned, to integrate when and where it is feasible. Integration of humanitarian and national health systems frequently offers widespread benefits in terms of planning and sustainability, cost effectiveness, and continuity of care for both displaced and host populations. Planning for the potential for long-term displacement from the earliest phases of the crisis, even when politically unpalatable, can make integration more financially and operationally accessible if the crisis does become a setting of protracted displacement. Yet contextual questions around state fragility, current health system capacity, and the politicalization of healthcare deeply impact the feasibility of national and humanitarian health system integration, highlighting the importance of a nuanced and contextualized approach towards health system strengthening. In order to plan effectively, decision makers must have access to sources of information for identifying health needs and gaps present in both the host and displaced populations. Existing health information systems, as we heard, are often incomplete and rarely facilitate the breakdown of information by displacement status, although we see the Colombian health system information system offering a promising model for addressing this challenge. Large-scale displacement can challenge health systems and limit the availability of health services for both the host and displaced population, as well as trigger or exacerbate issues around accessibility, accountability, and quality. This can drive displaced communities to seek care in expensive, informal, or private settings, or away from seeking care at all. Task shifting and promoting links between community and facility-based care can also help address some of these challenges, particularly around some of the gaps that we saw in mental health care, disease management, and specialized care. However, despite these opportunities, affordability remains the defining issue in determining access for many displaced and even host populations. Out-of-pocket medical and direct non-medical costs were a persistent concern across all 4 sites. As we heard in the presentation on DRC, the inability to pay pushed many would-be patients away from seeking out formal health care at all. These issues and potential solutions are not isolated, but instead sit within a greater socio-political ecosystem in which both the determinants of health and access to healthcare itself are often determined by the legal status of displaced individuals. This project illustrates the vital role legal status plays in ensuring the ability and willingness of displaced populations to access health services. Lack of formal documentation can have far-reaching consequences on when and how people access care, as can government restrictions, as we saw in Bangladesh around the bureaucracy in accessing out-of-camp referrals. Comparatively, Colombia's policy of legal status for displaced Venezuelans shows promise in increasing health insurance coverage and thereby improving the access and affordability of care. Legal status is also closely linked with the social and environmental determinants of health. We see this in camp complexes where the availability of things such as clean water and housing are largely dependent on the camp management, and in urban settings such as Amman, where refugees are legally restricted from working outside of specific, often low-paying sectors. Addressing determinants of health through a whole-of-person approach serves as the foundation for preventative care, leading to long-term, sustainable improvements in health that can ultimately decrease the burden on health systems and health financing. In protracted displacement, it is particularly critical that responses incorporate these elements, including education and livelihoods, as an integral part of health planning and financing. As protracted displacement appears to be with us for the years to come, it is vital to embed the whole of person within the broader conversation around supporting long-term resilience of refugees through a lens inclusive of education and livelihood strategies to not only promote the strengthening of the health system itself, but to address root causes of poor health and promote better health and well-being for host and displaced populations in the years to come. Thank you. I'll hand it over to Monette.
Thank you. So, as I promised, we've reached the point where you get to ask some questions. We have about 80 people, I think, online. And we have folks walking around with microphones in the audience here. There is a very strange thing going on right now on the screen. So let me just... Just 1 second. So for those of you who are in the audience, please do feel free to put your hand up, identify yourself, and ask a question. We'll take 2 or 3 at the same time so that we can prime the panel. Gentleman over there in the corner.
Thank you. My name is Wilson. I have 2 questions. Number 1, how do you model or predict future conflicts? Because it's really hard to do that. As I said to some of you, like I'm from Ethiopia, and we didn't expect, a war to come in that fast. And how can you predict? What kind of predictive models do you use to do that? And number 2 is, by 2050, it's estimated that there will be like 1.2 billion climate refugees because of global climate change. And the International Convention does not recognize them as refugees because refugees are usually the 1951 Convention. What do you think is going to happen when, I don't know, 1 billion or 1.2 billion people are forced out of their houses and homes? And how can we be ready for that? Thank you.
Okay, so question on climate change. I'm trusting that my panelists will have registered the first question. Can you remind me what it was, sorry, very briefly?
I mean, how do you model future conflicts, to get ready for future conflicts?
Okay, thank you. Let's take a couple more questions from the audience. Any more? Yeah.
Thank you, and thank you for the brilliant presentations. My name is Marta. I'm affiliated with Mammon School of Public Health. And I was just wondering whether there's some case or like country examples on how do you handle chronic diseases, right? Like we've been talking a lot of mental health, and then there's a lot of communicable disease. We've seen a lot of TB, HIV services available, also maternal and child health care. But with the obvious rise of NCDs, I was just wondering whether there are some examples on how do you handle that at the health system level. Thank you.
Okay, so let's take those questions. I'm having a little bit of problems getting the questions from the folks online, but let's take those 3 questions. One on modeling and predicting future conflict, one on the impact of climate change, and the third on the management of chronic diseases. So I think in terms of thinking about the chronic diseases question, Fuad, can I call on you to share a couple of thoughts on that particular question, and then if others want to add on, please feel free. Fuad, are you there?
Hello?
Yes, you're there.
Okay. So I see the same question also on the chat by Dr. Suhail from Jordan, also about considering cancer, as a part also of a priority. And I think, this is very important, talking about NCDs. And in our project, we consider diabetes as an example of NCDs. But we know that chronic diseases, including, non-communicable diseases, are major, especially in protracted crises. And all examples here, we're talking about long-term crises, and that means considering that now is a priority in the humanitarian system. And we have a lot of evidence that chronic diseases in fragile settings, including conflict settings and the humanitarian context, also suffer from NCDs. As per the question about cancer in specific, well, this is a major challenge. And I do agree that this is important to include, but I also see that how the issue of challenging that could face the humanitarian system in addressing such a sort of high-tech, and highly expensive, disease. Whereas still, however, I think that this is an important one to see, can we have a new approach when we consider NCDs in the humanitarian settings? Over. I will leave it to others if they want to add anything else.
Fernando, please.
Thank you very much. I think that I will start with my comments on the question of NCDs. This is a critical issue across the globe. It's not only for those people in forced displacement situations, but it's really for all the population. And the answer is very much focused on the primary healthcare level. We want to strengthen the primary healthcare level to expand the early diagnosis, the monitoring and the tracking, and the early monitoring of processes that eventually lead to complications. So it depends on the country and it depends on how you do it, but the answer is primary healthcare. It's at the first level that you really need to track and monitor your populations. And to do that, of course, you need a good information system. And by investing in those systems, you are investing in the health system in general, but also you might be able to respond not only to the forced displaced populations, but to the broader populations. We've seen in many countries, the populations are, the diagnosis of patients with cancer may come later for those in forced displacement, and compared to the the rest of the population. And that's why it's so important to invest at that first level of care. It's not only the treatment. Frequently people think of cancer already as the treatment of cancer, but it's critical to identify the risks and to intervene very early on that. There are plenty of examples of successful integration on primary healthcare level. What's missing, I think, is lessons learned from all these different contexts. There is also a very important investment that we need to monitor, which is early childhood development. So having primary healthcare monitoring the children from the earliest stages, even when the mother is pregnant, is the key to many important improved outcomes, even eventually at the long term, chronic diseases and potentially cancer. In terms of climate change, clearly this is an issue that everybody is worrying about. How this will become a legal issue to be resolved, I don't know. But from the health system's perspective, clearly this is a public health, public good issue, and we need to strengthen that. And we are very much interested in the bank to support how we are moving ahead with prevention and also strengthening the public good health systems. So we are investing, for instance, in different types of laboratories, different types of capacities. Key case, for instance, Africa CDC is an emerging very good example, and we want to make sure that we invest in those so that climate change also is, the response to climate change is an early detection system and coupled with obviously strengthening the health system. But again, my key message would be the investment on primary healthcare level, learning the lessons, and making sure that we have an early detection system, early diagnosis system for adults and also for children. Thank you.
Thank you, Fernando. I mean, I would like to call on any of the panelists who wanted to add to that, because I think you've given a very fulsome answer. I mean, in terms of the potential future impact of climate change and modeling future conflict, I mean, I think there's a whole array of actors and researchers out there who are working in this space. From the health systems perspective, I think as Fernando has pointed out, we sort of know what the system needs to do to sort of build itself up and be resilient. The real question for us in the course of our research was the surprising finding that, you know, sort of no matter who we spoke to across the 4 sites, everyone acknowledged that we know that displacement is likely to be protracted. But making those investments in structural change, integration, incorporating displaced early on so that the system itself as a whole gets strengthened is something that was very politically difficult for many of the national officials that we spoke with. And so there's this collective denial that's sort of built into the system. And so we continue responding on an emergency basis for a long period of time. That's something that clearly emerged from our findings. Les, I see you want to add something on that.
No, I'd like actually to answer your first question about predicting wars. We can't. The University of Maryland has come up with a really sophisticated, complicated way for trying to do this and thinking of it epidemiologically. Their predictive value positive for the highest risk places are like 40%, 50% likely in the next 5 years. Who 4 years ago could have predicted Ukraine? Some Ukrainians probably could have, but others would have said, yeah, the Russians invaded, they got it worked out of their system, it's gone now. So we can't do it. Adding insult to injury is the United Nations does a great job of measuring violent deaths and deaths in certain crises like Venezuela and Syria, and they just do a crap job not measuring 1/10 of violent deaths in Mali or Niger or the Central African Republic. So we can't.
Well, keep a hold of that microphone because we have a couple more questions that have come through on Zoom, and if there are others in the audience, please feel free to add. But let me share a couple of the ones that have come through on Zoom. So first of all, a question for the DRC team. To what extent could the fact that health centers don't have data disaggregated by displacement status actually be a sign that integration is well and good and displaced are treated like the hosts? So that is a question for our DRC team, that lack of sort of data disaggregation in DRC. So that we have a question also for Bangladesh. And that question basically flags the fact that Bangladesh has witnessed famines, typhoons, and a number of natural disasters, and as well as displacement. And so the question is, does history provide Bangladesh with the experience and expertise that in some way has facilitated its response to the Rohingya crisis? So those are two questions, and I think there was one in the room. Dr. Ball, yeah.
Hello, my name is Juliana Ball. I really like this slide on planning and integration, and I sort of flipped it in my head to planning for integration. And so I'm thinking in terms of, I think, DRC, Bangladesh, et cetera, where you already have these parallel health systems. And I'm wondering, what kind of recommendations would you make if you were to plan to integrate that health sector in terms of approaches, what needs to change, especially considering that you have hundreds of NGOs already operating there and a reluctance of donors to actually directly fund the health system and make the kind of improvements to ensure that there is actual strengthening of the national health system to enable it to provide services to IDPs and refugees. Thank you.
Great. So 3 questions. Let's start with Team DRC, then Bangladesh. Oh, yes, absolutely. So Team DRC, Les is asking you to weigh in on that question, gang. Are you there?
Yeah, I already asked the question, answered the question in the chat. I said, what would be the added value for a health structure to start separating IDPs, refugees, and nationals, because they are all the same. There is no system that is supporting one side or the other. Money is the criteria to access health care. You have money, you get care, you get treatment. You don't have money, sorry, go away. And the other question, like as it is appeared in Colombia, that the health system is administered. You can see the government putting in effort. You can see the health practitioners trying to support both sides, but it's not the case in DRC. It is, you have money, get treated. And why would the health structure or a health assistant start separating and asking questions? Are you an IDP? Are you a refugee? Are you a local citizen? Knowing already that there will not be any separation between the two. It is money in hand, fine, money not in hand, no, goodbye.
Goodbye. Thanks, gang. Les, anything you wanted to add? No. Dr. Green, Bangladesh.
Sure.
Has history helped?
Yeah, I mean, I think this is a tough question. I'm not sure I'm going to give you a fully satisfying answer, but I'm also going to try to answer your question, Juliana. I think what we heard in our interviews, at least, is that... Sorry.
Oh, we might just have to mute gang.
Oh. Well, I hope he was helping me answer the question, but I guess not. So I think it's complicated. I think what we heard a lot in our interviews is really, and what we saw, I mean, historically, we've seen these repeated waves of displacement of Rohingya to Bangladesh, getting to the very first question we had. And then we're seeing also this history within Bangladesh of emergencies and needs from the host community. And one of the things that we heard in our interviews that I think was quite interesting was that kind of the response, there was this real tension between kind of not only the services and health services that are available for the host versus the displaced population, but also the impact of the presence of and the response to the displaced population on some of these climate-related concerns in the local community, the host community as well. And I think one of the things I'm reflecting on is, to answer the question, I'm not sure, because I think that the strategy that they've taken in Bangladesh is really to keep these systems separate, which makes me wonder, I don't know if we can really, I'm sure there's a lot we can learn, but I'm not sure that those trajectories are really converging in a way that would allow us to take a more integrated approach in the case of Bangladesh, given the approach that's currently set up and how kind of parallel and siloed those are. But it has created a lot of tension, and I think as a result has led to the promising policy, which is that really the services and the health sector was really the one example where there was some intention to provide some access points for integration, but functionally, as I described in the presentation, I think that was a lot more difficult in practice than it was on paper in many ways. Not sure that really answered the first question, but it was the best I can give.
No, that served perfectly well. And I think I'm conscious of time, and I'd like to use Dr. Boll's question as our pivot to the last series of comments from our panelists. Lessons learned moves towards integration in each of the 4 sites, or perhaps in some of our financing systems. Wu, you look very intentional with the microphone, so I might ask you to comment first on sort of a couple of the lessons learned for those 4 studies, and then just be primed everyone else. You'll have a chance to also weigh in from your country perspective.
Sure. Perhaps I can start with just following Claire's comments on the Bangladesh. I think, and for this project, I didn't go to Bangladesh, but I know Bangladesh has a very vibrant NGO sectors. There are many NGO facilities. I think with even though we predict there might be more issues in Bangladesh because of climate change, those things, you leverage the strengths of the NGOs in the healthcare sectors is quite important. Another thing I think we can leverage on is the community health workers. And I also understand Bangladesh also use community health workers a lot. That's kind of task shifting, and can also, with the kind of short training, they can do a lot of things to provide the services. In terms of the integration, as I mentioned in the slides, Colombia might be the one with the best example here. The integration perhaps can be at 2 levels. One is at the financing level, whether we can have the governments and the donors work together to co-finance services for the displaced population. In Colombia, you can see the government basically includes some of the Venezuelan migrants into their health insurance schemes. And the other, I think in Jordan, they also start thinking about it when they're designing the nationwide health insurance. Another level in terms of integration is more at the services delivery level. Use the government facilities. I think in many of the countries, they are still working on that. In Bangladesh, the referral hospital is mostly a government hospital. I think so. What we recommend is more like a streamlined referral process and better use of the government facilities or the facilities in the NGO outside camps.
Great.
I'll stop here.
Thank you. To the folks on Zoom, perhaps Diana, anything you wanted to say just in response to Dr. Boll's question about prospects for integration? You're so far advanced.
Yeah, I do think Colombia is a really great test site to understand how integration may work, and also the challenges with integration. I will point out that Colombia would be a great place to examine the impact on offering chronic disease services and other services in an integrated setting. In a companion piece that we published with funding from ELRA and the UK government, we actually looked at this during COVID-19, and we found that once Venezuelans are integrated into either contributory or subsidized regime, the inequality in access to services completely reduces. So that does speak to the fact that if you're worried about chronic disease, cancer care, and you are able to integrate into the system, then there is an improvement or a potential improvement for inequalities. The other thing that I would say, this is a previous question about can we predict into the future? Well, I agree with Les that we cannot, except that migration and migratory patterns are increasing. I think we thought that this might reduce during COVID, and on the contrary, we have even more migrants and refugees. And I agree that there needs to be a new category of climate migrants. And Colombia, again, is another example. They have more than one crisis. They have internally displaced migrants, and I think we can add another category to that, which is going to be the climate crisis as well. So those are my comments. Thank you.
Great, thank you, Diana. I'm looking at Les and Fuad on screen. Any final thoughts you wanted to share with us? We're at time, so they would have to be brief.
Well, thank you, Monette. I do join my voice about the concern about the climate change migration. This is a major issue, and it's good to add it to the big questions on the issue of forced displacement. Over.
Great. Dr. Roberts.
Yeah, this has been a wonderful exercise, Monette. Thanks for organizing it. Thanks for the World Bank for funding it. But we haven't been completely honest. Everywhere in the world, locals know how to do healthcare best. In the worst crisis of the world, in the poorest places of the world, the international community brings a check against corruption and theft. Like, that's the main thing they do. And we just need to figure out how to use those two assets as they exist. Thanks.
All right, then. Well, I mean, you've given us a lot to think about. I have to say, as Fernando mentioned right at the beginning, this is, I think, the beginning of a process. These reports, these studies surfaced many, many questions, suggested some key areas to focus on, but there is clearly still a lot of work to be done. And I just wanted to really thank my wonderful panelists here for their work over the last 3 years, but also the time they've taken to present it in a very tight time frame to you all. And also the many members of the consortium who aren't represented in person or on Zoom today who contributed to this study and were on some of those early slides that I shared. It's been a huge team effort, and I just really wanted to thank my fellow researchers, our panelists. I also really wanted to thank Columbia Global, and the Department of Population and Family Health for helping us put this event together. And finally, our wonderful student volunteers, without whom we really couldn't have brought this all together throughout the last 3 years, but also this event itself. So thank you all very much. A round of applause to you all.